14th, 1968. Olympic Games, Mexico City. Jim Hines runs the 100-meter distance in 9.95 seconds. World record. August 16th, 2009. World Championships, Berlin. Usain Bolt breaks the world record and sets the new mark on 9.58 seconds. 40 years professional sports. 40 years sports medicine. 40 years development and application of newest technologies for 0.37 seconds. And as we heard before, this is sometimes similar in dentistry, and a good example represents the selection and performance of specific treatment options in plastic periodontal and implant surgery. Because, like in sports, we have to accept limitations. And like in sports, being a little bit better, being 0.37 seconds faster, very often means a great additional effort for the patient. I mean, first of all for us. And from our perspective as dental professionals, this great effort normally is not that much of an issue. But mainly also for the patient. And from the patient's perspective, things look sometimes different. Treatment outcomes viewed through the eyes of a patient, patient-reported outcome measures look sometimes different. Do I really need this soft tissue graft? Do I really need to have this hole in the palate? And if it's really necessary, how could an adequate amount of tissue be obtained while at the same time reducing post-operative pain and reducing the risk of complications? And aren't there maybe soft tissue substitutes that could replace autogenous soft tissue grafts? These are questions very important to patients, and I will keep these questions at the back of my mind if I now want to share with you my thoughts on soft tissue autografts, and by doing so I'd like to guide you through the following menu. I'd like to share with you some thoughts, critical thoughts, on the so-called unpretended gold standard. From there I would like to go with you through some critical aspects with regard to the wound healing outcomes after soft tissue augmentation procedures. We will continue and share some clinical lines of thoughts before I at the end try to give you a global perspective on future and current trends in soft tissue augmentation procedures, and at the end I will draw a conclusion. Well, autogenous soft tissue grafts have characterized the last 50 years of clinical periodontology. Until now, we have to say more than ever. A variety of soft tissue grafting interventions are carried out with two targets being pursued. It's increasing the width of the keratinized tissue and increasing soft tissue volume. The epithelialized graft, the free gingival graft, is considered as gold standard to increase the width of keratinized tissue, and the subepithelial connective tissue graft is considered as gold standard to increase soft tissue volume. If from now on we focus on the subepithelial connective tissue graft, and if we critically evaluate this gold standard, we will realize that there are some points that need to be discussed. First of all, it's beyond question that among eligible donor sites, only those come into consideration that do not go along with major complications risk, and of course, those that at the end promise an adequate amount of obtainable tissue. Under these requirements, the human palate, the masticatory mucosa at the human palate, has emerged as the area's choice for subepithelial connective tissue graft harvesting. So the masticatory mucosa consists of three histological layers, the epithelium and the subepithelial connective tissue with the lamina propria and the submucosa. The epithelium is characterized by alternate keratinization around 300 micron thick, and the lamina propria again consists of two layers. We have a papillary portion that shows finger-like projections in the overlying epithelium, and we have the reticular portion with at the main part having thick and dense reticular fibers. And last but not least, we have the submucosa, which is a connective tissue layer with numerous glands, nerves, and adipose tissue. So besides the histological composition of the masticatory mucosa at the palate, also the thickness was measured in different scientific investigations with ultrasonic devices, periodontal probes, needles, also computer tomography or combinations, coming out with a mean thickness of around 4 millimeters. So although it needs to be taken in consideration that obviously thickness as well as histological composition at the masticatory mucosa at the palate is very, very different from site to site and also from patient to patient. Obviously, two areas have emerged as the areas of choice for subepithelial connective tissue grafting, and respecting the palatine neurovascular bundle as a very important anatomical structure that needs to be protected, two areas of choice have emerged. This is the anterior lateral palate, and it's the posterior lateral palate with the tuberosity area and the posterior lateral aspect. What does this mean? Well, if we talk about the gold standard, this suggests a well-defined and consistent standard procedure. But looking at this drawing, you will realize that obviously there is no standardized harvesting procedure at the palate. And just looking at this picture, it easily illustrates what I want to say, because all four of these connective tissue grafts are autogenous subepithelial connective tissue grafts harvested at the palate. But all of them look different. Of course, this one, the upper left, is harvested at the anterior lateral palate with a single incision technique. On the upper right, it's harvested with a trapdoor approach at the posterior lateral palate. The lower right is a subepithelial connective tissue graft from the tuberosity area, harvested with a distal wedge technique, and the lower left is a free gingival graft de-epithelialized outside the oral cavity. So of course they look different. They have a different geometric shape, of course, because the amount of attainable tissue is different at the different sites. This is not that much of a problem. We can fold it, we can suture it, we can slice it, we can unfold it how we need it. But also, all these grafts have a different histological composition, and of course they have. They are harvested at different sites with different harvesting techniques. Of course, the histological composition is different. That this is not only a clinical impression, I can show you in an investigation we did in our research group, the one that Rino mentioned already at the very beginning, where inside another scientific project we also were investigating the ultrastructure of different subepithelial connective tissue grafts. So here's an example harvested from the anterior lateral palate, where we just excised a small piece and made them ready for histology and morphometric cytology. So here you see the histological picture of this example. You see at the bottom the periosteum, on top of it a rather loosely arranged tissue, a lot of extracellular matrix, some few collagen fibers in black. The black dots are fat cells, glandular tissue and vessels. If you even look a little bit closer, and this is now a picture done with a transmission electron microscope, you see a mast cell there, you see collagen fibers there, and these pictures can be used for a so-called cell counting. And if you analyze now our specimens, that's what you see here, and if you focus here on the graft from the anterior lateral palate, you see that there are differences. So less collagen, more extracellular matrix, more fat and glands. So the clinical, let's say, impression that the histological composition is different can also be substantiated. So in summary, we can say there are things that need to be discussed with our gold standard. And there's one more thing we already heard before. Of course, if it comes to gingival recession treatment, There's one procedure that came out to be the best one. All the systematic literature reviews, as you've seen before, common sense, it's the coronally advanced flap with autogenous subepithelial connective tissue graft. On the other hand, there is a lot of uncertainty regarding the true effect of these grafts. We always think it's the thickening effect. But on the other side, it could also be the anchoring effect that is the true effect of this graft, meaning that the graft is able to stabilize the flap in a coronal position. It could also be the protective effect. This means that if, for whatever reason, the connective tissue graft would fail to stabilize the flap in a coronal position, if flap retraction occurred, there is still the graft on the surface allowing healing by primary tension and a successful root coverage. And last but not least, it could also be the long-term effect of a creeping attachment. So this is not really clear at the moment. You might say, well, I didn't need to know the true effect. I don't care. If it works better, I do it. But I'd like to try to tell you that this would make a big difference if you would better understand the true effect. But if, let's say, it would be the anchoring effect, once in a sudden, for us as clinicians, it would be much easier. Less complication rate. For the patient, smaller grafts, less morbidity. And last but not least, if necessary, we could, of course, treat more recessions at the same time if the grafts need to be very thin and small. So this would make a big difference. In summary, we can say at that point, yes, it's true, the subepithelial connective tissue graft is considered as gold standard for soft tissue augmentation procedures today. On the other hand, looking critical to this gold standard, there are things that need to be discussed. There's uncertainty regarding the true effect of the graft, and it's also evident that we are using, all of us, different grafts harvested at different sites at the pellet with different harvesting techniques, having different histological compositions that might end up with different characteristics. And so the question is, can the histological composition of a subepithelial connective tissue graft influence the wound healing characteristics after a soft tissue augmentation procedure? And this is something we did also, as the other speakers before, so we had the opportunity in our group to compose a literature review within the frame of the 10th European Workshop on Periodontology that recently took place in Segovia in Spain, where we analyzed all the literature in the context of soft tissue replacement grafts, also with regard to the wound healing characteristics. And so we can say till today that based on animal experiments, mainly related to free gingival grafts, we can say that the survival of soft tissue autografts is dependent on a fast and adequate blood supply by plasmatic circulation and later on by means of revascularization. No discussion. The better the blood supply from the recipient bed and from the flap, the more stable the connective tissue graft is embedded. The thinner the exudate between graft and recipient bed, the more easy plasmatic circulation can occur and the more living cells in the graft will survive. If at that point we continue our questions, can the histological composition of the graft really influence the wound healing outcome in such situations? There might be some influences we could think about. Different grafts could influence the physiologic process of revascularization. Different grafts could behave different with regard to their potential to induce keratinization. And different grafts, as it's obvious, might have a different volume stability. Just by clinical experience, we might assume that obviously connective tissue from the more posterior area or harvested superficially, which is denser and firmer just by looking at it, seems to have a lower tendency for shrinkage. And at the same time, we might hypothesize that this denser and firmer tissue, on the other hand, might not have that good requirements for the physiologic process of revascularization. We might even assume that among suitable connective tissue grafts, those appear to have a better property for revascularization, have worse, let's say, prerequisites for shrinkage and vice versa. So this is what we find clinically, and let me please share you at that point Just as a clinical example, my experience with the de-epithelialized graft, so the free gingival graft that's de-epithelialized outside the oral cavity. It's a type of graft I started rather late with, so for whatever reason, but it became very popular, and for a good reason it became popular. One thing is, you are very fast as a clinician. So if you harvest connective tissue that way, you are very fast. Second, you can also take this type of connective tissue graft in situations where the masticatory mucosa is really very, very thin. You can harvest a lot of tissue since you don't even approach the area of the deeper vessels. And as mentioned before from a clinical experience, this tissue seems to be dense, it seems to have a high quality, and seems to be less prone to shrinkage. So that's why I used it and still use it today. So here would be a clinical situation, and if I go and think about gingival recession treatment today, I have always the tendency, so if I can omit surface incision, verticals, cutting through the papilla, I do that. And if you go for tunneling procedures specifically in single types of gingival recessions, of course we have limitations in the coronal advancements, and so we can live easily with parts of the connective tissue graft being exposed to the oral cavity. Sometimes we do this to increase the width of keratinized gingiva, but sometimes you just have to because we cannot enough mobilize the flap in a coronal direction. This is normally not a problem with, let's say, a conventional type of connective tissue graft. With this type of connective tissue graft, I faced quite some problems in my clinical environment, and this is only one of those examples I can show you. And this is lesson one I learned. If you use this type of graft, you always have to cover it completely. So the histological composition seems to have a clinical impact. Lesson two. A very similar clinical situation. Now I learned already that I have to completely cover the graft. So this is mandatory, this needs to be done, but look at this. After 6 months. Well, this is really a problem. How could this be explained? Well, one option would be that by de-epithelializing the graft outside the oral cavity, we leave some parts of the epithelium on the graft, this is clear. And then I would say in less than ideal situation, a very, very thin flap, let's say for example, this type of graft might behave similar, like a free gingival graft with all the consequences. On the other hand, it would be possible, this is only a hypothesis, that the more we are superficially in the subepithelial connective tissue, the more aggressive the morphogenetic inherent factors for keratinizations are in the subepithelial connective tissue. This hypothesis could even be supported scientifically. And here this is a clinical study with 6 patients, just a few patients, where they harvested quite thick free gingival grafts. They cutted these grafts in half and used both of them. On one side the free gingival graft, on the other side the subepithelial connective tissue graft, to increase the width of keratinized tissue in the lower posterior segment. 3 months after healing, they took biopsies, they made histology, immunofluorescence, and they found clearly that on the side of the free gingival grafts, they found all characteristics of the masticatory mucosa at the palate, and at the side with the subepithelial connective tissue graft, they found both characteristics from the masticatory mucosa at the palate and from the alveolar mucosa. So this would be just, let's say, scientifically something that might somehow speak in favor of this hypothesis we just discussed before. Once again, in summary, although written evidence lacks at the most part, today we can say that obviously different grafts with different histological compositions seem to really influence the healing outcomes of the soft tissue grafting procedures. They seem to have different characteristics that might require a very selective clinical application. And so let's share some clinical thoughts on the situation. I mean, it's always like this. As soon as we start to harvest connective tissue at the palate, it's always the challenge to get enough tissue and at the same time reduce patient morbidity and reduce the risk for complications. So this would be a single incision technique at the anterior lateral palate. So make sure, if you can, to raise enough thickness, let enough thickness in the flap, allowing healing for primary tension. Leave this soft tissue step inside. So that's what it looks like with the periosteum on the upper side. Very similar if you go for the second option, which is a free gingival graft, as mentioned before, de-epithelialized outside the oral cavity. So the incision design is very similar. Create an adequate thickness for the graft. Make sure that you go too deep. This might have a negative impact on patient morbidity, as we know from the literature. So make sure that this is done. Make also sure that you really completely remove the epithelium outside the oral cavity. So this needs to be done carefully. This requires also your assistant to support you. So this is this specific type of graft, very dense, very stiff. And last but not least, the distal wedge technique to harvest a subepithelial connective tissue graft from the tuberosity area. So this is a typical procedure. Of course, you have to remove the epithelium, and then you can use it how you want. You can slice it, you can unfold it, depending on the situation where you use it. Just some clinical examples that show that already today we play with the different types of connective tissue grafts depending on the situation. So here it's a gingival recession. And of course we go ahead. This is a de-epithelialized graft used here, very thin. Make sure that the flap is not too thin. Make sure that you completely cover it. I always would turn it around today, and here a good indication for this type of graft in this type of procedure. Another indication, so here I selected for soft tissue rich augmentation under orthodontic. I selected the posterior lateral palate to harvest connective tissue, as you can see here, folded it, sutured it, the superficial part of the graft, always inside. So the soft tissue augmented, as you can see here, and the final situation with the final resin bonded bridges and the final patient. Another situation, here it's an alveolar ridge presentation, here with an immediate implant. I went for a graft from the anterior lateral palate here, as you can see, including periosteum sutured to compensate for the defect formation after extraction, and here the healing outcome after 6 months, final restoration, and the final patient. And the last example, an implant reconstruction, so soft tissue reconstruction in combination with implants. Here I decided for a graft from the tuberosity area, de-epithelialized, sliced, unfolded at the time of implant uncoverage, and the final situation here. So already now, today, at least by clinical experience, we play already with different grafts in different clinical situations. So in reality, as clinician, today obviously you will somehow map the palate. So you can use an endodontic needle for that. With more experience, you just need the needle of your local anesthesia. Look how much tissue is available, and then you decide depending on the indication you are going to treat. So that's what I wanted to show you with these clinical examples. That's how it's done today. So the goals, the challenges for the future are very clear. First of all, we have to better understand our gold standard. I think this is the most important thing. We have to better understand the molecular regulations of revascularization. We have to better understand the responsibilities for the epithelial differentiation, and we have to gain better knowledge with regard to the volume stability of different types of grafts and different types of procedures. And I think the potential today to measure volumetric changes over time is become very, very good. So by having this technology, having the possibility to, with three-dimensional optical scanning and subsequent virtual superimposing, allows us in a previously unforeseen precision to follow volumetrical changes over time, and I think this is what we have to use in the future. So this is just one example from our group where we use this technology in a randomized controlled clinical trial, analyzing the tunneling technique with autogenous connective tissue as a test compared to a coronally advanced flap with enamel matrix proteins as a control in gingival recession treatment. But instead of making hand measurements with a periodontal probe, we use this optical scanning pathology, and so at the end we made expressions. We had a lot of models available at the end, as you can imagine, that needed to be scanned and superimposed. Interesting is the second part of the publication where we were focusing on the horizontal dimension. And now look carefully what nice informations we can get just by using these new technologies, because we can really one-to-one measure the soft tissue volume on the originally exposed root surface, as you can see here, and we can come out with very important information for us in this context. So you can see here, 6 months after treatment, we have more soft tissue volume at the test site. This is not surprising, because we used, in addition, subepithelial connective tissue graft, all of them harvested at the anterior lateral palate with the single incision technique. But now it's getting even more interesting. It seems to be stable. After 1 year, I added here the numbers after 2 years, because we have them already available, and you see at the moment it's quite stable. And it will be very interesting to follow these cases in the future, if the thickness will remain stable and if there's still a correlation between thickness and percentage of root coverage. So I think this is becoming very important in this concept, and this needs to be used, and I'm totally convinced if further proceeding in development in soft tissue augmentation procedures is the goal, to volumetrically evaluate and compare the long-term stability and efficacy of different soft tissue replacement grafts by using this technology is one of the major goals in the future. So at the end, if it comes to future requirements and challenges, it cannot be different to develop soft tissue substitute materials that one day might allow us to really completely get around those autogenous soft tissue autografts, to get around those holes at the palate. But this is not so easy. This is really not so easy, and from our understanding, the question is very obvious. How would you ever develop a soft tissue substitute measuring up with the gold standard if you haven't yet understood the gold standard? And so I truly believe that probably we have to go one step back, further improve our understanding of the gold standard, which is the autogenous connective tissue graft, and probably then it will be much easier to develop, based on this knowledge, a soft tissue substitute at that point of time. So let me conclude. And this coming now back to the question I got at the very beginning. Is there really today still an indication for autogenous connective tissue grafts? And my answer is very clear. Although written evidence is lacking at the most part, yes, I do believe there is still an indication for autogenous soft tissue grafts today. Of course, at the end, the goal cannot be really different from really developing a material that really allows us to obtain from autogenous connective tissue grafts. And at the end, I'd like to show you this drawing. This is not more but the Minoan labyrinth from Knossos on the Aegean island of Crete. Most of you know this. They know this from the myth of Ariadne, who saved Theseus' life by supplying him with a thread that helped him to exit the labyrinth without getting killed by the Minotaur. But believe me, this is much more than a love story. This labyrinth is used till today more like a roadmap to master successfully specific challenges and duties in life on any psychological level, represented here as this white dot in the center of the labyrinth. And this helps a lot. So let's take a specific challenge in our life. If you want to go through it, if you really want to achieve it, sometimes it's very good to know that sometimes, although it feels that you're already very close, you're already there, but in reality there's a very, very long way to go. And sometimes the opposite is the case. You feel as you were very, very far away, but in reality you're very close. If you now break down this labyrinth to our goal, developing a soft tissue substitute for our patient, and if somebody would ask me, where do you feel? Where are you? I would say, honestly, today I feel we are quite far away from our goal. There's just some distance to go. But we should not give up, because this would allow us, at the end, to be a little